talked this morning, there's some of it that it should help and have it make more sense. And then we'll go from that into talking about the difference between VA and VV, also seeing if that ties in with what Rachel talked about with gas exchange this morning. And then we'll take a break, and then I think I'm actually going to have Kim do team roles and responsibilities first, so I can take a longer break. And then we'll finish with specifically looking at pediatric and cardiac reasons for ECMO. So in terms of cannulation, I'm going to pretend to be a surgeon. Can't still be offended. I do my best approximation possible. So when you think about cannulation, and this is relevant too when you start thinking, when we start doing the talks on pediatric, cardiac, and neonatal ECMO, is as soon as you start thinking about having a patient that you believe meets criteria for being cannulated to ECMO, one of the parts of your thought process should be what kind of ECMO do you think that this patient should be cannulated to? And part of that is whether they need VA versus VV, but the other part has to do with which way they're technically going to be cannulated. Now, certainly this is a collaborative discussion that we have with our surgical colleagues. In general, the way we do cannulations here is that if you are in a NICU or in a pediatric ICU and someone needs to be cannulated to ECMO, it's the pediatric surgeons who come and do the cannulation. If it's somebody who's in the cardiac ICU, the cardiac surgeons will do the cannulation. We have two cases recently where pediatric surgery cannulated cardiac kids. One of them was in the cardiac ICU, but we've now clarified that just to make it a little bit easier in terms of process. And when we talk tomorrow morning about actually cannulation process, it'll become clear to you how all the right people get notified. So just suffice it to say they do. So you have this discussion with the surgeons, and this is where both of you understanding what the goals for the patient are and what the limitations of what we're doing can inform the decision. So VA versus VV, and then where, and then the size of the cannulas, and then the types of cannulas. So in terms of the general number of sites, and Jim specifically, most of these slides are from Jim Stein. When you think about non-central, there are really two places in VA ECMO that patients get cannulated if it's non-central. Jugular and carotid really basically go together, and then femoral as the alternative. Or you can have combinations of those. And then VV as a double lumen cannula, it always goes in the jugular position, and then occasionally we'll do VV that's not a dual lumen cannula, and that would be a jugular and femoral. So for neonatal cannulations, typically where we end up cannulating these babies to in the NICU is through neck cannulation. So for the neck cannulation, when you talk about the venous part of the cannulation, it's the right jugular that's used. And so why do guys suppose that they use the jugular? Right, exactly. So it's easy to visualize and have access to. It is, the right jugular is a straight line connection to the SVC. So if you have long, stiff cannulas in place, having something straight is important. And then even have relatively decent bleeding control and ability to apply pressure if you're having bleeding. The other nice thing about it, besides being a straight shot to the right atrium, is that it's a short cannula. So going back to what we were talking about this morning with Poisson's law, it is true that if you can have a shorter cannula, that's better. And then the other part that's important is that you can have jugular and other venous drainage on the other side, because you will have some occlusion of it. So then if you're cannulating someone to VA, so that's how you get into their venous system, and neonate, if you want to get into their arterial system, is generally through the carotid. And why there? Same, you're already in the area, right? Because you're already in cannulating the jugular, so you move next door to the carotid. And then it allows you to have access to the arch. And again, there's multiple inflows to the brain, so we think that we maintain perfusion to the brain. And there's a never-ending debate that once you finish your cannulation, whether you reconstruct or you don't reconstruct the carotid. I think I can do that later on. So for neonates, this was just to give you an idea, again, of what we showed earlier on the slide. So for neonates, when you're looking at single lumen cannulas, typically we'll talk about venous cannula being somewhere around 12 to 15 French in size, and then the arterial cannula will be somewhere between 8 to 12. In the NICU, you guys pretty commonly will use 10 French. You consider it small when you get to an 8 French. So here is an example of an x-ray with a neonate cannulated to VA ECMO. So the important thing here is starting to think about where you want your cannula position to be. Use my pen as a pointer. you have your cannulas come in, obviously the patient's head is to the side, so one of the things to think about in these neonates is they're little, so however they're positioned when they're being cannulated, you have to think about whether that's the same position they're in when you take them out of their cannula, their actual surgical procedure, because if their head is out to the side and you have flows to one capacity, if you then take that patient off of a neck roll, or you take them and you try and straighten their head out, or your cannula is going to be in the same position, because, can you guys see, or is there too much glare from the windows? You can see? Okay. So here comes your arterial cannula down. So one, I know that this is arterial because it's a little bit smaller than this one. It's also more medial. And then where do you guys suppose the tip of this cannula is? What? Oh, ascending aorta, right. So this is your arterial cannula. It's coming down your carotid and it's going somewhere into your aortic arch. And so a part of this for me, which Jim doesn't make as big of a point about that as I do when I give this talk, is that we will have the never-ending debate when we have problems with flows that it's the cannula position. It's not the cannula position. It is. And part of the reason why we have that is it's so difficult to position these cannulas, especially when you do a neck cannulation. So if you look at this cannula, what you want to do is you want to position this cannula somewhere in the aortic arch so that you're getting good blood flow to everything. And if you think about a 10 French cannula in a neonate, doesn't that sound monstrous compared to what we typically put in? It does. And so how do you put a cannula into the aortic arch so that you get good blood supply to all the head and neck vessels and potentially retrograde flow to the coronary arteries, but not occlude the aorta when you're putting a cannula in so that you don't increase the resistance so much on the LV that it doesn't have the capacity to function? So while we give our surgical colleagues a hard time about the cannula position, it is not an easy job that we task them with. So this is probably somewhere around the ascending arch into the transverse arch, ideally is where it's positioned. Here's your venous cannula coming down. So venous cannula is coming down the internal jugular, and then where do you guys think that this cannula ends? Little dot. The little dot down here, correct. So most people look here because this is where the wiring ends. But the truth is that your cannula typically ends well below that, because if this cannula were here, what position would this be in? It's in the SVC, right? And so now, if you're taking venous return, all you're doing is getting about 40% of venous return from the SVC. And if you're really trying to maximize the amount of flow through your circuit, either for oxygenation purposes or to decompress the heart, if you don't get what's coming from the IVC, that's not good enough. And so this actually shows you where the true tip is. So obviously this child is rotated. It's hard to imagine that the right atrium goes over here. But typically what you're looking for is the tip of the venous cannula to still be in the right atrium. So it's got a good distance to travel. Make sense?
Where is it coming down on the arterial? Like, there's something that's able to go superior as well?
This is it. This is your entire cannula. This is coming from outside carotid into the transverse arch, and this one's probably starting to go down the ascending arch a little.
Do you get flow in the carotid then? Or?
Right, so that's what you're hoping for, is that you flow through your arch, and then you may or may not get good retrograde flow around your cannula in the carotid, and so mostly you sacrifice, and then you're relying on all the other redundant blood flow to go over and infuse the other side of the brain.
So the goal is putting it in the right carotid so that you can still go across the arch and up the left carotid and still perfuse the brain.
Exactly.
And that's another reason why they prefer the carotids over any femoral arteries or something, because you go femorals for perfusing the lower extremities and then getting the rest of the blood flow after it comes to the lower extremities to the upper, so you have decreased perfusion to the brain.
Yeah, we'll
So
see
by
the
going
femoral in a minute.
upper neck, you actually get more proximal or early, better oxygenation perfusion to the brain.
But you're counting on it going from the left carotid up and over. Good? That's the easiest of them. In terms of pediatric cannulation, there's more diverse processes that happen, which means that you can have different, and there's more going on, and there are bigger kids, so there are more options. So in pediatric, as opposed to neonatal cannulation, when you think about venous cannulation, yes, you still have the jugular as an option, but actually the femoral start to become more of an option on the venous side for bigger kids. So if you're doing a jugular cannulation, it's the same things we just talked about for a neonate. It's easy access, you're there, and it's a short distance to the right atrium. If you're doing a femoral catheterization, you're going from the femoral, and again, the whole idea is how much of the blood flow can you drain from the body. So if they put a femoral cannula in that only goes a short way up the IVC, now you're only getting 60% of the venous return. If you put a femoral cannula that goes in all the way up to the right atrium, it's a very long cannula. So typically you have much more resistance through the femoral cannulas than you do through the jugular cannulas. But you don't impede the venous drainage from the brain by doing a femoral cannulation. And then when it comes to arterial, again, you can go through the carotid, so it's short and you are going right into the arch. But people worry about whether there's more risk of cerebral ischemia potentially because of, do you really have good enough blood flow across the circle of Willis to the other side of the brain? And then you can go through the iliac and have a cannula come up as your arterial cannula. I think the next, here's a picture of these. So I think this tells the story more so than anything else because, so here's your femoral venous cannula coming in. So look at how long that line is. If ignore the not quite upper venous structures, as opposed to if you had an IJ that was just coming down here. So you have a lot more resistance going here to your pump and your oxygenator. And now this is what Kent was talking about, is that when you put your femoral arterial line in, the question is how long is that line? And typically, it doesn't go all the way up to the arch because, again, longer and longer and longer, more and more resistance. So now it's hard for your centrifugal pump to flow because it's got high resistance on the front side and then high resistance on the afterload side. And it can only generate so much pressure. And then depending on where it stops, yes, you can perfuse your abdominal organs really nicely with this cannula, but how much of it is actually retrograde flowing up here or is really all your coronary artery and head and neck vessel perfusion coming from the heart itself? So it really depends on what reason you're going on and how much you can rely on your lungs and how much you can rely on your heart to help you out when you're thinking about a femoral arterial versus a carotid cannulation of the musical limbs. Make sense? Central cannulation. So those are, and that was all just VA. We'll do VV in a second. So the pediatric surgeons will do those cannulations. Occasionally we'll have kids, not occasionally, in cardiac ICU, we very routinely have kids cannulated to central cannulation. So what's the difference between central and these more peripheral cannulation sites? So first of all, this heart here shows you, so this is a very large blown up picture of this pediatric heart. So pediatric heart only this big, which is again important to keep in mind when you think about the head and neck vessels and when we're screaming that you have to position that cannula in the right position, how hard it is to get in that place. So when you do a central cannulation, what this picture is showing you is the venous cannula is coming right in directly to the right atrium. And then you have your aortic cannula coming in here to your aortic arch, and then this is the left atrial vent that we'll talk about in a second, in this case coming out and being wide in. So those are your three cannulas. There's other things in this picture though that I want to highlight to you, and that is this structure right here, this blue structure. So what this blue structure is since they are now directly cannulating into the heart and into the arch itself, these are less stable cannulas than when you have them going through the neck, because when you have them going through the neck, you have more subcutaneous tissue, or through the leg, frankly, to help hold it in place. So what are the things that you can do to help stabilize these? So one of the things that the cardiac surgeons do when they do this cannulation is that when they make these incisions, they run a purse string suture around these, and then leave the purse string suture in place so that when you're on call in the middle of the night at 2 o'clock in the morning and the cannula pops out and the chest is filling up with blood, you can grab that purse string suture and cinch it down. Piece of cake, right? No problem. So, yeah, not so much,
right.
no, right? So part of what they do to make it easier for us in our moment of panic is that the sutures aren't just free floating in here. What this actually is that they'll either use a red rubber at some institutions, or here they use these blue, they're not straws, but I'm gonna call it a straw for a minute. So when they do their purse string suture, they pull it up and then put it over, through. They put this through the blue tube, and then they put these clips on here relatively loosely, so you can still cinch it down, but tight enough that it's not gonna fall off of your suture. So what you have to find is this, and then find the tail of the suture hanging out of it, not that there's just suture free flowing in there. Did I explain it well? So you have two, you have one around your right atrial and you have one around your aortic, and then you would have a third if you had a left atrial vent in place. And the other thing I didn't put in this talk, that I wasn't thinking about, is that you can see how many structures are lying within the mediastinum here. So when you go to look at your chest x-ray for cannula position and a central cannulation, it's much more difficult to tell where your cannulas are. You can tell where your cannula is in the right atrium, but you'll never be able to see the tip of your aortic cannula because there's too many different things overlying the structure. Not to say you shouldn't try, but good luck. So for a central cannulation, here's your schematic, and so they're directly cannulating into the right atrium. Typically they put in the right atrial appendage. If they say it to you, it doesn't matter. For your intents and purposes, it's in the right atrium. And then it goes out to your pump and your oxygenator, and then they place it directly positioned in the transverse arch, which in many cases is actually easier for them than it is for the pediatric surgeons, because they do this under direct visualization to be able to put the tip in the transverse arch. So what's your guess as to how far a cannula is in when they place in the transverse arch in a neonate? How much cannula is inside the patient's vascular structure? Not a couple more centimeters. It's typically only in about 2 to 3 millimeters. So when you talk about these cannulas not being rock solid stable, they're not rock solid stable, and that's why whenever anybody goes to the patient's bedside, you'll see the ECMO specialist lay hands down on their cannula to make sure that they're not being disturbed. So that's why the purse string sutures are so important, and some of the other things that they do to help secure them. And now you can see that when it's in the transverse arch, yes, you have antegrade flow from the heart. So again, your coronaries, the first thing your coronaries see is whatever's coming out of the LV, but you have more capacity to have retrograde flow to your coronaries, and then you'll get good antegrade flow to all of the head and neck vessels. So central cannulation is nice compared to neck because you can get bigger cannulas in since they're going directly into the right atrium here instead of that 12 to 15 French size that we were talking about. The smallest venous cannula I ever anticipate somebody coming out of cardiac OR with is an 18 French venous cannula. So we're never limited on the venous limb from a cannula size in this case. So you're going directly in, you get a bigger cannula, and then you get a better cannula, not better, but it's easier to get directed in the placement of your aortic cannulation. The downside to this, though, is what we talked about, less secure cannulas, and then they leave the sternum open when they do this. Obviously, you can't close the sternum around this. In the really big kids, occasionally they close the skin, so you get a little bit better of an infectious barrier, but the majority of the time, both the sternum and the skin are separated, and there's just a patch in there with an IO band over it, so it is a big infectious risk. So that's the downside of central cannulations, and we try not to do them in things that are going to be longer runs. With the left atrial vent, so why a left atrial vent? Well, the reason for left atrial vent is that when we talk about ECMO, we're going to use the words full flows all the time. But when we say full flows, it doesn't necessarily mean that you are fully decompressing the heart. So in general, when we are flowing somebody on this kind of right-sided cannulation for VA ECMO, typically you're only decompressing 60 to 75% of the blood flow. So your heart still has to handle somewhere around 25, 30+% of the venous return for the body. So if you have someone who's got depressed function, but it's not completely gone, then that works out okay because this takes it off and then the heart handles some and sends it through the pulmonary arteries to the lungs and then back to the left side of the heart and out to the body. But if you have somebody who has primarily LV dysfunction or you have horrible dysfunction, what ends up happening is that as the blood flow goes through and gets to the LV, if the LV isn't strong enough to eject it, especially if it's fighting against the resistance of a cannula in the aortic position, what do you suppose happens to the LV? it dilates. And what happens to LV when it's non-functional and it dilates? Does it work any better?
It's not gonna get better.
No, it definitely doesn't work any better. And not only does it not work any better, but we also think that the dilated heart has impaired coronary perfusion, because the same thing about Poiseuille's law applies to coronary arteries. So that as you dilate the heart and the coronary arteries get stretched out, their diameter comes down and they get longer, so the resistance goes up. And so then it becomes impossible for it to recover. So how do we help the left heart? So the way that we help the left heart is by actually decompressing it also. So here's the blood flow through. So as the blood flow goes through over to the left side of the heart, what they'll do is they'll go posterior to the heart, as you saw in that picture, and put a cannula into the left atrium, and then this gets wide into the venous limb of the circuit. So it goes into the venous limb. So you've got blue systemic venous return going through your right atrial cannula, and then your left atrial vent has your pulmonary venous blood that's coming and blending in with that. So in that case, what can you not rely upon? Your SpO2, because it's contaminated. So again, this is where it's really easy to get sign on a patient and say, okay, yeah, this one's just getting to VA ECMO, they have an LA vent place, yeah. But if you don't stop and actually think about it, it doesn't give you the right amount of pause. So you go to this patient's bedside and the nurse tells you that the lactate is 60 and they haven't peed in 6 hours, and you say, yeah, but my venous sat is 85, so can't be any problem going on here. No, there is a problem because you have an LA vent in play.
Could you do atrial or septectomy for decompressing as well?
That's another option. So what Jose is asking about is in a patient who has LV dysfunction that gets cannulated to ECMO, because sometimes in our myocarditis run, so cardiomyopathy, a patient who has cardiomyopathy, and we know they have cardiomyopathy and they're being cannulated to ECMO, in general, that patient is working their way toward a VAD and a heart transplant, because cardiomyopathy is progressive and doesn't really have a chance of recovering. Myocarditis patients have a chance of recovery, though, and myocarditis tends to affect both the right and the left ventricles similarly. So you oftentimes have LV dysfunction, and so just having this right-sided cannulation isn't enough. And so then the question is, in those patients, do you do a neck cannulation because they're going to be a long run, but then you still see that you have problems with your LV? In some cases, those kids will then be converted to a central cannulation because you put the left atrial vent in place, and we'll get a biopsy if there's any real question about what the diagnosis is. But if we really know what the diagnosis is and we want to maintain the sterility of the mediastinum, then what will happen is, instead of putting in an LA vent, is that they can go to the cath lab and have an atrial septostomy done. And so now as the LV pressurizes and the left atrium pressurizes, you'll have left to right shunting into your right atrium. Can you count on your SpO2? No, because again, you still have your pulmonary venous return going out there. So you just have to know. As the heart recovers, there should be less and less shunt across that ASD. There'll always be some, because left-sided pressure is always higher than right-sided pressure. But as the LV recovers, it should start to go down. So what you should see over time is what?
SpO2 may go down.
So SpO2 will start dropping, and what else will happen? If the heart is working better and sending more blood to the body, what's going to happen?
PaO2 could go down.
Right, the patient's PaO2 will start to go down. So the same thing that Rachel was talking about this morning. So often we're tuned to think that when SATs go down, it must be something bad. But in ECMO, oftentimes it isn't, because your oxygen in your ECMO circuit is so much more efficient than anything that the body honestly does. So that then if things are getting worse, either it's that your oxygenator is failing, or is it actually that your patient is getting better around your oxygenator and you're starting to see some of their own physiology emerging? Good question, Jose.
I've not seen a NICU baby with this LA event, and that could very well be because I just haven't seen that many. But do they do that in neonates?
No, if we do it in neonates, it'll never be done in the NICU. Because the ones,
Okay, it doesn't happen.
yeah, the only patients who get an LA vent are patients who have profound failure, and so you guys may put them on a VA. Well, I guess you you guys have had central cannulation. Can you imagine that they would do an LA event in the NICU and not move that patient to the cardiac ICU? Do you think they would? With the cardiac surgeons, have they done it?
Mhm.
Cardiac surgeons come up and do
It
it?
was Cindy, it was a long time ago. We had a patient, we couldn't get enough venous drainage on for one, so she came in and opened the chest and did a central cannulation on that kid. But I don't,
It would be rare.
Yeah,
So I
it's
guess we
been-
can't say rare. It would be rare. I only
I
know
want to say it was
one
probably
other.
6 years ago,
Yeah.
7 years.
So the NICU generally does neck. I know one central cannulation in the NICU in the last 6 years. And that was because when they were doing the neck cannulation, the IJ got lacerated off of the SVC, and so they emergently converted over to a central cannulation in that kid.
Right.
But even that has a lot of consternation because you're just not used to having open sternums. I'm surprised that that kid stayed in the NICU. I think if it happened, there would be a debate about whether that kid stayed in the NICU or came to the cardiac ICU. In part, because if you're putting an LA vent in, depending on what's going on with the kid, if the kid's going down the cardiac pathway, then those kids usually come to the cardiac ICU.
Yeah,
And
neither,
more-
that other one I was taught was not for cardiac reasons.
Right.
It was just for,
You know, one thing I never thought about in the NICU population that would be kind of interesting to look at and think about is how many of the neonates, so most of your guys' kids go on for respiratory reasons and have pulmonary hypertension, so that their right side is more pressurized than their left. I wonder if the neonates that go on for primary cardiac failure, how many blow open their PFO and shunt left to right across their PFO if they have LV dysfunction, since it hasn't been closed for very long. Kind of interesting question. Maybe a research question for somebody. Okay. Keep going. So in terms of steps for cannulating, we'll talk about this tomorrow also, but just in general, that there has to be a discussion between the surgeon and the intensivist in terms of whether this patient is an appropriate candidate, how they're gonna go on. Consent is an interesting thing that we'll talk about, and then what happens with perfusion, anesthesia, the positioning, all these other things. I'm gonna leave this until tomorrow. Okay. Double lumen cannulas. So this is for VV double lumen. So so as tricky as it is to think about positioning your VA cannulas, I think positioning a VV cannula is much more difficult. So there are certain things that they will traditionally look at, like these rules that Jim gave here about 2/3 of the distance between the sternal notch and the xiphoid, and then looking for it on x-ray. But it's not actually that simple. So here's a patient who has a VV double lumen cannula in, and somebody walks by and says, is this cannula in a good position too? And I would tell you that as soon as you hear a patient has a double lumen VV cannula in place and they ask you to read the x-ray, you can't read this x-ray and comment on position until you know what kind of cannula they have in place. Because there are two types of VV cannulas, and this is what Rachel was starting to allude to when she was talking about recirculation this morning. So the, God dang it. Why did it not? Twice today, all right. So the first kind of cannula that there is the origin cannula. Now this is the one that we most commonly use in the neonate population. So what's important about the origin cannula is knowing how the ports lie. So the reason I'm groaning is because I actually have a slide where this is over there and then there's an upright picture inside a heart. But if you imagine this upended, right, because really your lumens are going to be coming down here from the IJ. So the way these ports line up is that the venous return part of it, all the ports are on one side of the cannula. And then, so the blood comes out, goes to the ECMO circuit, and then gets oxygenated and comes back in. And when it comes back in, all the arterial ports are on the opposite side from the blue venous ones. So you have a right and a left to a cannula is basically a way to think about it. So in that case, if you have a right and a left, where do you suppose you want, and they're all pretty close to the tip of the cannula, where do you suppose you want this cannula position? Right, you want it smack dab in the middle of the atrium, and so this also gives you a visual for what Rachel is talking about in terms of thinking about recirculation. Because if that's the only difference, blue blood's going in on one side and red blood's coming out on the other side, this is why you have this recirculation. Because if this is all going into the right atrium, ideally the way this is positioned is that these ports are in the right atrium and that they're pointed toward the tricuspid valve, so that as that blood is coming in, it's as quickly as possible exiting the right atrium. But if it doesn't exit the right atrium very quickly, then it can sort of swirl in the right atrium, and as it swirls, and all of a sudden you've got red blood going up the blue blood slide, and that's what we mean by recirculation. And I think I have some slides on recirculation, but you can start thinking about what would minimize that. One way of minimizing it is to change the kind of cannula that you put in. So the second type of venous cannula that we have is something called the Avalon cannula. So the Avalon cannula also goes down to small neonatal sizes, but here we don't use it in the smallest neonatal size because we've had a problem in the past where it eroded through the IVC because it's a stiffer cannula than the Origin. So technically, some people do use this in neonates, and we're probably going to come back and revisit that because that happened a million years ago. But what's different about the Avalon cannula than the Origin is that in this case, instead of having the ports line up so that the blue ports are here and the red ports are here, what it is that you have venous ports up here in the top of the cannula, and then you have venous ports in the very distal part of the cannula, so proximal and distal. And then you have one arterialized port that sits somewhere in between these. So now the positioning of the Avalon cannula, if it's in best position, is that you have the tip in the IVC with the side port being properly sized so that it can be up in the SVC, and then your arterialized blood is the only thing in the right atrium. So it minimizes the amount of recirculation. So with the Origin cannula, typically the way those are placed is just percutaneously at the bedside, making estimates on the position, and then once they finish getting an x-ray. When we place Avalon cannulas, which is what we typically do in the pediatric ICU, we will do them with radiology right at the bedside because there's much more manipulation that has to be done with it, and so they'll do it with, ideally it's done with fluoro, but you can't always make that happen. You just do x-rays while everybody is still scrubbed to figure out whether you have to move it around or not. And sometimes
Do
you do echo.
echo?
Usually they'll do echo afterward to confirm position, not necessarily at the same time. Do you guys do it at the same time ever? I think it's
Well,
always.
we don't do fluoro,
No,
but they'll
the
do the
echo.
echo, usually after.
Right. So does that make sense, the difference between those cannulas and why that's so important? So in theory, you have less recirculation with this one, which is why we want to go back and revisit it. So overall, what can go wrong when you're cannulating? Everything can go wrong when you're cannulating, which is why we have a whole talk just on cannulation, because it's not simple and straightforward. But so as I implied earlier, you could have vessels that are too small, so they walk in and say, for the size of this kid, I want to put in a 14, and then they dissect out the IJ and realize it's never going to be a 14. Oh, it's never going to be a 12. Oh, I guess I get just stuck with a 10 at this point. You can have vessel tears, like I talked about, that there actually was a patient that happened to not that long ago. Even if the IJ itself looks like it's a decent size, once they go to put the cannula through, maybe there's an area of stenosis, bleeding, cannula movement, and then whether or not you have good flows or not. That is, I thought I had. Oh, I think it's in the VA and VB talk that we'll do next, that we spend more time on recirculation. Questions on cannulation?
So when you're following to make sure it's in the right place, because it doesn't seem like X-ray is going to tell you that level of detail. So is it really based on just the function of what it's doing, or?
It's both. I mean, X-ray can tell you some of it, because this cannula, if this was an Origin, this would be in an okay position, right? Because the tip is sitting in the right atrium where you want it to be, and the cannula is obviously labeled with the ports so that you know which one is medial and which one is lateral, so when the surgeons lay it down, they don't reverse the side to it. So in this one, you can kind of tell from the positioning. I would say this is a little high, but you can see if you come down, it's not too much further before it starts to exit. But if this was an Avalon, this would be way too high, right? Because this tip is all within the right atrium, and the side port at best is in the SVC-RA junction, so you're going to have huge amounts of recirculation in this patient. that's why they get the VVs, they get the echo afterward to confirm placement. 1 minute.
Do you automatically use reperfusion catheters with your femoral cannulations, or only if you have an issue, or never?
Oh, yeah, I didn't talk about that in that slide. Yes, let's go back to that. So the downside, the other downside to femoral cannulation is that if you are now putting a catheter through the femoral iliac and into the IVC and you're perfusing this way, the question is do you still get good blood flow down your femoral artery? So leg ischemia can be a significant issue in these patients, and so it's what people think about. So there are a multitude of ways that institutions handle that. Some institutions put the cannula in and wait and see if they have other problems or have problems with leg ischemia and do close monitoring of the leg. The last kiddo that we had here cannulated this way, they used a special cannula that has 2 ports on it. And so it has one larger lumen that was running approximately to be the perfusion, and then there was a smaller second lumen that they tucked into the descending limb beyond the insertion point, and so that it had differential blood flow through that. There are other systems where people will jerry-rig it so that as this is going up, they'll take a piece of tubing off and then redirect it into a cannula to perfuse the lower extremity, but then you just have to be careful on the size of that cannula so that or that tubing, so it's not too big, so you don't have massive flow going down to the leg and stealing a bunch of flow.
The last girl had like a 6-French cannula, that's what they used, because there was a loop coming off of it, and then it was just about a 6 French, I think they said.
Yeah, compared to the mid-teens that she was, because she was a big girl.
So you mentioned ASD just very quickly. You could have an ASD and you're trying to project from the RA, is there a high likelihood it's not going to be an efficient venous draining?
Is there a high likelihood what?
That you're not going to get an efficient venous draining?
It's not that you'll get excellent venous drainage, but what your venous drainage is going to be is both systemic and pulmonary venous drainage. So when you think about our